This microscopic view shows chemical neurotransmitters rapidly flooding and sparking across a dense neural synapse. People often use bipolar as casual shorthand for mood swings. In reality, it is a complex physical neurobiological condition that affects 2.8% of adults in the United States. The challenge with diagnosing this biology starts with human behavior. People rarely visit a doctor when they feel highly energized. They almost exclusively seek professional help when they hit rock bottom during a severe depressive episode. Because that deep low is the only state they describe in the exam room, physicians treat the symptom presented to them. This frequently leads to years of misdiagnosis, treating the patient strictly for standard unipolar depression. This data graph reveals the danger of misdiagnosis. When a patient with bipolar disorder is prescribed a standard antidepressant without a mood stabilizer, the external chemical can cause their baseline chemistry to spike violently into the red zone, actively triggering a severe manic episode. Applying the standard depression playbook here fails to cure the patient. It actively accelerates the disease's volatility. To understand why that medication backfires, we have to investigate the hidden half of the disease that the doctor didn't see during that initial consultation. A diagnosis of bipolar I requires a strict clinical threshold. The patient must experience at least one true manic episode, lasting for 7 or more consecutive days. Clinical mania is separate from simply feeling happy or energetic. It presents as extreme grandiosity, racing thoughts, pressured speech, and a sudden, sharp decrease in the need for sleep. This side-by-side clinical taxonomy chart maps out those extremes. On the right side of the chart, the behavioral criteria for clinical mania reach dangerous upper limits, resulting in a high probability of risky behavior or full psychosis. Bipolar I is defined by these profound physiological peaks. That specific brain chemistry requires an entirely different medical strategy than unipolar depression. There is a related category called Bipolar II, which pairs those same major depressive episodes with a distinctly less severe elevated state. This comparative timeline illustrates the difference. The steep 7-day peak of Bipolar I sits next to a significantly shallower 4-day peak for Bipolar II. This shorter, milder state is known clinically as hypomania. Notice how the shallower 4-day peak fades into shadow. Patients rarely perceive that brief lift as a medical issue. They usually just feel highly productive. So when they finally speak to a doctor, they only report the deep, visible depressive trough. Because bipolar brains operate on a distinct chemical foundation, introducing an antidepressant to those hidden sparks of hypomania acts exactly like pouring gasoline onto a fire. Achieving clinical stability is impossible until a medical professional identifies and categorically diagnoses these hidden biological states. Given that chemical volatility, trying to treat bipolar disorder with therapy alone is structurally insufficient. The first mandatory pillar of treatment is specialized medication prescribed by a psychiatrist. This typically involves mood stabilizers like lithium and lamotrigine, or atypical antipsychotics. The second mandatory pillar is targeted therapy. This includes modalities like cognitive behavioral therapy, interpersonal and social rhythm therapy, or family-focused therapy. This is a symbiotic architecture of care. Without chemical stabilization, therapeutic techniques cannot take hold in the brain. And without therapy, medication alone cannot build lasting behavioral resilience. Coping and healing counseling was built explicitly to execute this dual-pillar model. They deliver targeted therapy while directly coordinating your care with outside prescribing providers. This vector map of Georgia shows all 159 county borders, illuminating at once. They cover the entire state with over 15 licensed therapists. Watch those borders transition into a sprawling network of encrypted lines, completely removing geographic barriers to specialized telehealth care. They also remove the financial barriers, accepting major insurance providers including Aetna, Cigna, Blue Cross Blue Shield, United Healthcare, and Humana, with session copays ranging between $0 and $40. For Medicaid patients, the copay is $0. You can connect with their team today by visiting chctherapy.com or by calling 404-832-0102. Warm, concluding complexities of bipolar disorder should never be a dangerous guessing game. It requires a safe, clinically coordinated path